Good morning. My name is Dr. Sharan Nair. I'm a senior lecturer at Maha Institute of Dental Sciences. I'll be taking my topic on intracanal irrigants. We will be going through the following headings. We'll be first an introduction to the functions of irrigation, and we will be discussing in detail the other various irrigants such as physiological saline, sodium hypochlorite, EDTA, chlorhexidine, iodines, oxidized potential water, ozonated water, MTAD, and Russell solution. Moving on to the introduction, the complexity of root canal morphology presents a challenging objective to the endodontic community. These complexities hamper the ability to thoroughly achieve pulp cavity disinfection. The objective, therefore, is to remove all of the pulp and dentin debris from the root canal system. Biomechanical preparation and chemical preparation are used concomitantly in order to debride the root canal system. Biomechanical preparation attains free access to the apical foramen through the access opening and through the root canal system by mechanical means, which exposes, enlarges, and shapes the root canal. At the time of biomechanical preparation, suitable irrigants are used which help in achieving debridement and disinfection of the root canal system. Moving on to the functions of irrigation and irrigants, mainly we have to have irrigants should be having antimicrobial activity. There should be a flushing action so that the debridement of the canal system can happen, dissolution of necrotic and vital tissues, lubrication, removal of smear layer, and bleaching action. Moving on to the first irrigant, most commonly used one is the physiological saline. It comes in a concentration of 0.9%. It's primarily for the flushing action and it's very biofriendly. Hence, it has some disadvantages such as the absence of any antimicrobial property. It's incapable of removing the smear layer and incapable of dissolution of necrotic tissue. Basically, the physiological saline is just used for the flushing action. Moving on to the next one is sodium hypochlorite. Sodium hypochlorite is the most commonly used intracanal irrigant. It's a strong oxidizing agent with a clear straw colored liquid and available as 5% chlorine. It's commercially available as chlorox of pH of 10.38 to 10.9. It should be stored in a lightproof container. The stability of sodium hypochlorite is reduced by lower pH with the presence of metallic ions and exposure to light. When you keep it in a container, make sure that the container is kept closed and it is kept at normal room temperature, not at very high temperatures. Volume of irrigants and concentration. The most commonly used concentration of sodium hypochlorite ranges from 0.5 to 5.25%, in which the 5.25% is what is commonly used. Now, the low concentrations such as 0.5 or 1.5, 2.5, even 3%, the low concentration of sodium hypochlorite, the efficacy, the antimicrobial efficacy is reduced when the concentration is less. But this reduction in concentration can be utilized when you use the same sodium hypochlorite in the same concentration, that is less than 5.25 in larger volumes, frequently change the solution and longer period of exposure can achieve the same results as a 5.25% sodium hypochlorite. The general report for the volume of irrigant used per tooth amounts to 5 ml. It has been shown that usage of 3 ml of NaSO at 5.25% is sufficient to cause effective debridement with antimicrobial effect. Baker and Associates, however, advocate the use of 20 cc to flush off 5% NaOC. Smear layer removal. The smear layer produced by instrumentation was not removed by sodium hypochlorite as proven by Garbarogolio and Bees and Gold. This is of significance since retention of smear layer can increase time required for disinfecting, inhibit or delay penetration of intracanal irrigants, medicaments, dental tubules, prevent adhesion of oxygenating materials to the root canal walls. So removal of smear layer is a very important aspect of root canal therapy, and we have to find a material that will give maximum removal of the smear layer. Now, sodium hypochlorite, how the mechanical action is there? The germicidal activity of sodium hypochlorite is because of formation of hypochlorous acid. It permeates the cell wall and combines with the protoplasm, dissolves necrotic tissue because of high alkalinity. Biopolymers like proteins are hydrolyzed into amino acids. Sodium hypochlorite reacts rapidly with glycine in phosphate buffer at 20 degrees Celsius. The adverse effects of sodium hypochlorite. Now, when using sodium hypochlorite, one should be very careful as not to create an iatrogenic accident such as the sodium hypochlorite accident. The inadvertent injection of sodium hypochlorite into the soft tissues can elicit a violent and frightening response. The cause of this emergency can be related to both the irrigant and the irrigant technique. Mechanism from injury is primarily oxidation of proteins followed by inflammatory reaction. This response is similar to that proposed in angioneurotic edema with the release of histamine or histamine-like substance, vasodilatation with subsequent transudation of plasma accompanied by hemorrhage. The amount of tissue destruction depends on post-response, volume of irrigation, concentration of irrigant, temperature of irrigant, and the spread of the solution. Again, the amount of tissue destruction depends on post-response, volume of irrigation, concentration of irrigant, temperature of irrigant, and the spread of the solution. That is how much of solution has being pushed out is directly correlated to the area where it spreads. Now, according to Sabala and Powell, the sequence of events after the hypochlorite accident are as follows. There is excruciating pain within 2 to 5 minutes. Burning sensation will be felt by the patient in the affected area. Immediate swelling of the tissue in the area will spread to surrounding loose connective tissue. Profuse bleeding episode either interstitially or through the root canal system. Over the next few days, the pain subsides to constant discomfort. Swelling persists over a week and progressively subsides. The interstitial hemorrhage may result in ecchymosis over the skin, because of which the affected skin is discolored. Moving on to the next very commonly used intracanal irrigant is EDTA. NAIR in 1957 introduced EDTA with the following formulation as an adjuvant in root canal therapy. Ethylene diamine tetracetic acid disodium salt, 17 grams, distilled water, 100 cc. EDTA is an insoluble, odorless, crystalline white powder. It is relatively non-toxic and only slightly irritating in weak solutions. It has a pH of 8.3. The disodium salt of EDTA is usual form employed in dentistry, adequately buffered to 10 to 15%. The effects of EDTA have been reviewed by Seidberg and Schindler. EDTA has a dentine dissolving effects desirable in all kinds of RC therapy. Reduce the time necessary for debriding, aid in enlarging narrow and obstructive canals, help bypass fragmented instruments, not corrosive on instruments. Antimicrobial activity of EDTA is neither bactericidal nor bactericidal, inhibited with the growth of and eventually destroyed bacteria by the process of starvation. Metallic ions in the medium which were necessary for growth were chelated 7, rendered inassimilable by the microorganisms. Cohen and Burns discuss the functions of EDTA. It is used as a lubricant. It can be used for the removal of smear layer. They also cite references and report that EDTA has been dispensed in 2 forms, viscous and aqueous. The above of the 3 functions listed as viscous product is used for the first 2 during canal preparation, whereas the aqueous solution is used as the final flush after shaping and cleaning of the smear layer. The antimicrobial effect, Yoshida and Associates found a 15% EDTA solution to possess significantly better antimicrobial properties as compared to saline. Bahara and Torabinajad found the solution to be of antibacterial benefits after 16 is 1 week of exposure. At the same time, exposure time to such magnitude may not be practical clinically. For pre-gingival, the solution had good antibacterial effects. However, other authors have proven that EDTA possesses at best a limited antibacterial activity. Produces a limited antibacterial activity. Sen and his associates have shown that this product may possess antifungal activity and also have cytotoxic effects. The antifungal activity will be explained. Because EDTA chelates to calcium, it prevents binding of C albicans to proteins in a dose-dependent manner. It removes the calcium from the cell walls and thereby causes cell walls to collapse. Also inhibits enzymatic reactions. Cytotoxic effects. The alkaline EDTA solution found to be moderate to severely cytotoxic. It has been reported that 5 to 50 mg EDTA may be found in related tissues with the exposure of EDTA. 1% concentration of EDTA equals 26.3. This, when extruded, may lead to decalcification action on a periapical bone, neuroimmune regulation, and even very low concentrations. Thank you. This concludes the first part of my presentation. Thank you.